Hi, very good afternoon, dear colleagues. It's really my great pleasure to present today to you the data from EBC MAIN study and to exchange our experience and study results, to discuss also with my colleague Bea Vaquerizo from Barcelona. So hi Bea.
Hello, good afternoon.
Welcome, and I think we have today really very interesting hour according to the interventional treatment of distal Leftman stenosis. And this is a really important topic, including our daily routine cases. And first of all, few slides according the introduction. So we have a small introduction, and then I will present the EBC MAIN study data. I think this is the study which was now presented during last EuroPCR. And then I show you 3-4 cases from study patients according the different approaches, including also re-angio. And finally, Bea she's really very experienced cardiologist in complex PCI. She will show us also 2 important cases, interesting cases, how to manage distal Leftman stenosis. One will be with single stenting and one with double stenting. And then I hope we will have some time for a discussion. And if you have questions, please write the questions in the chat. So according the revascularization guidelines, so we have now the newest European guidelines are from 2018. And here our clinical director, Professor Naumann, was the first author of these guidelines. If you just take a look to the Leftman stenosis, so you see if we go in patients with syntax score, in low syntax score up to 22 points, so low syntax score 0 to 22, you see we have green light for PCI as well, 1A class, and cabbage. If we have intermediate syntax score, 23 to 32, then green light is only here definitely for cabbage. We can go with PCI, but it's not the first line. And if we have even distal Leftman stenosis or Leftman stenosis in very complex anatomy, and this is just here shown in syntax score larger than, higher than 32, then you shouldn't go primary with PCI. So you have to try to treat such patients by cabbage. But this is, of course, a recommendation, and there are many factors which influence this final decision, patient's wish, and the question is how are patients suitable for cabbage, etc. And this must be discussed in the heart team. So in general, you will find the distal Leftman stenosis in around 3 to 5% of all cases with PCI. So many years back, we had really a lot of respect according to the treatment of bifurcation lesions, because we were not able to treat such patients correctly because there was no technical approach according kissing balloon maneuvers, double stenting techniques, etc. So for many years, it was, of course, the need to send such patients to surgery. But now, in last 10 years, we develop really very good technical approaches, strategies, how to manage bifurcation lesions, including distal Leftman stenosis. And you see a variety of distal Leftman stenosis, and they are sometimes really very, very difficult. Here, ostial LAD stenosis, Medina 010. Sometimes you can be really lucky and you can manage this anatomy with only one stent. checked by OCT. And this is a trifurcation. It's definitely clear in such very difficult anatomy. You have to achieve perfect result. You have to use double stenting, to perform double stenting. And what we know, what we observe in our daily routine, I believe Bea will see the same in her cath lab. If we have really very calcified distal Leftman, and it's really difficult to treat such patients perfectly with PCI, so you need plug the bulking, you need in patients like in this case, with severe reduction of LV function, you need also some hemodynamic protection, in this case Impella, to achieve reasonable result after stenting. And we still have problems, so there is still some problem with Leftman stenosis. If we have wrist stenosis, like here, you can treat this with stent-in-stent and then a drug-coated balloon for the circ in stent wrist stenosis. So this is one way to manage this, and this is what we do in our cath lab. If we have Leftman stenosis, you should know in majority of cases, in around 80%, it's a distal Leftman stenosis, and it's bifurcation lesion. And another important point is to know how is the plaque distribution in the distal Leftman stenosis. And normally the plaque extension is from left main to LAD in 90% the case. So usually, this is explanation why we usually go with a stenting from left main to LAD, because of this plaque distribution. And plaque distribution from left main to circ is in around 60-70%, and of course in many cases also a mixture of both. And another important information is that in more than 75% of cases, the diameter of the Leftman vessel is something between 4.0 and 5.75. And this is, if you should know this, if you go forward with PCI, you need such large stents to cover such lesions. And definitely IVUS OCT, so imaging, is according to the guidelines, also from the European Bifurcation Club recommendation. You should use it if you have availability, if you have such devices in your cath lab. And according to the approaches, we can discuss this later on, but you see we have on the one hand provisional side branch stenting, so you use only one stent and kissing for the side branch. You have here in the middle tap and culotte approach, which can be used as a primary planned double stenting procedure, or usually as a bailout stenting for the side branch. And both are, for both approaches, suitable. And if you plan primary, definitely double stenting, and you don't like to remove the wire from the main branch, then you can go with a stenting of the side branch first, and then first kissing, crush and kissing, stenting, pot, kissing, pot. So then you can go with a DK crush approach. Here just shown all steps, and you see you can really have to go step-by-step approach to achieve final result. And we have from Asia, from China, we have a few randomized large studies comparing different approaches in distal left main. One of them is here DK crush 3 study, which compared DK crush versus culotte stenting, and you see after 1 year there was MACE significantly different, showing the better outcomes if you use DK crush. But I would like to mention the difference came practically after 6 months. And another important study was Dickey Crush 5 study. And this is a study comparing, again, Dickey Crush, so systematic double stenting with provisional side branch stenting for the side branch. And here again, Dickey Crush versus provisional T-stenting. So it was allowed, of course, crossover was allowed, and doctors should perform here a kind of T-stenting, kind of TAP. And if you just take a look to the data from Dickey Crush 5, Dickey Crush versus provisional, you see after 1 year, there is target lesion failure significantly lower after Dickey Crush 5.0 versus 10.7. So suggesting or giving us the message, okay, if you go to the main branch, to the left main stenosis, you can go really ahead with Dickey Crush as first choice. And even if you see here subgroup analysis, you see the benefit for Dickey Crush and also the primary, secondary endpoints showing benefit for Dickey Crush. I was really shocked here. According to the stent thrombosis cases, there was significant difference after 1 year. So better results with Dickey Crush and lower angiographic risk stenosis, as you can see. Not significant, but by numerical comparison. So how we approach distal Leftman stenosis in Europe. So according to the recommendation from the European Bifurcation Club, so we recommend to go with single stent to perform final kissing and final pod. And however, in daily routine, you will find around 20 to 40% double stenting rate. In our center, it's exactly 36%. And how, if we plan the Leftman PCI, so you should, of course, consider here different access options, 6 or 7 French guiding. You have to prepare the lesions perfectly. Even you have to use the bulking techniques like rotablation or orbital atherectomy or IVL. And of course, if you have simple anatomy, you can try to go with single stenting. But if you have really very complex anatomy, you can go ahead with Dickey Crush. Post-dilatation is absolutely important. And you can see this is the data from ABC, which was presented this year during Europe PCR meeting. And our colleague, David Hildig-Smith, was the PI, and he presented the study. So our center in Bad Kreuznach, we included around 40 patients, and we were one of the top enrollers in this study. And you can see what was the background to plan this EBC MAIN study. So we have now more and more data, Nordic, BBC1, BBK study, Cactus study, all randomized comparison between single and double and systematic double stenting. And we had here a very clear message. Double stenting is not better than single stenting, even in larger through bifurcation lesions like ABC MAIN 2 study. And we have even some signals that maybe after longer follow-up, clinical follow-up, there is a maybe even higher mortality in patients treated with 2 stents. So how it looks by Leftman bifurcation. So one, I think, very important point is we have to manage here a larger vessel diameters. We have wider bifurcation angle, and we have usually more calcification and more fibrosis. So the need for an optimal lesion preparation is really very high. And we, the hypothesis of the study was the expectation that 2 stent, systematic 2 stent will be not better than single stenting. And on the other hand, we have the data from China, from my friend, Dr. Chen, supporting, as you saw in this slides from Dickey Crush 3 and 5 studies, we have really supportive data for Dickey Crush in distal Leftman bifurcation. And it was really important to have a European randomized study to check this point. And this is now data from our study. So we could randomize patients with distal Leftman stenosis Medina 111 or 011, and both branches should be larger than 2.75 millimeter. And single stenting strategy was one study arm, 230 patients, and double stenting, 237 patients. And we had around 30 patients, 30 European centers, including patients to this study. And we use it exclusively here, Resolute Onyx stent for this study. This was the idea behind, because this stent can go up to 6 millimeters in diameter. So it was really very important to avoid malapposition. The primary study endpoint was composite of death, MI, and TLR at 1 year. Some few secondary endpoints were also important. And in this is here just demonstration according the Onyx stent. There is very important information. We wanted to use the stent which is really suitable for bifurcation lesions with good access to the side branch. This is, I think, one very important point, with option to post-dilate the stent up to 6 millimeters, so, and with good radial forces and with minimal shortening. So for that reason, we use it Onyx Resolute as our study stent. And technical approaches are here shown: provisional approach, step by step, and POT and KISS were obligatory. And in systematic approach, it was left to the operator's choice to use TAP, culotte, or Dickey Crush. And again here, high pressure osteal bifurcation dilatations and KISS and POT were mandated. And you see, we have now in our studies more and more older patients. So they are now clear over 70 years old. We have here around 30% diabetic patients. And I think we also included patients with acute coronary syndromes and distal Leftman and significant distal Leftman stenosis. So more than 1/3 of patients were presented with acute coronary syndrome. And syntax score was around 23, similar in both groups. Radial approach around 70%, and six French sheath was used in around 60%. If we just take a look, it's clear in systematic double stenting, more stents were used, that's clear. But stents were also longer in double stenting group. Procedure time was significantly higher or longer. Fluoroscopy time longer, and X-ray dose also higher in double stenting, which is a clear message, and was also to accept, because double stenting is more complex procedure. And I think very important information was also how often crossover was necessary. And you see here in 22% of patients with provisional sideband stenting got finally double stenting, so at a crossover rate of 22%. And you see, even I was a bit surprised, even POT and key-sync, despite the high volume centers were involved, we don't have here really 100% final POT, final key-sync. It was really a surprise for me. And if we just take a look which technical approaches were used here, that's Collot. Collot is favorite. More than 50% of cases was Collot, and TAP in more than 30%. As you can see, Dickey Crash was used only in 5% of cases, few of them in our center. And so finally, if we have to go with Cypron stenting, you see Collot or TAP were used in the same way. And important also to know what was the reason for the Cypron stent. And you can see dissection in around 10% and residual stenosis in 12%. This was the need. This was the need for double stenting. And this is the primary study endpoint, a composite of death MI and target lesion revascularization. And you see 14.7 versus 17.7% by trend, a lower rate in stepwise provisional approach, and not statistically significant. And you see death, MI, stent thrombosis, and target lesion revascularization not different, not significantly different between both study arms. As you can see, there is even lower rate for TLR after provisional stenting. And this is some kind of another presentation, 15 versus 18%, and 6 versus 9% according to revascularization. So it was the conclusion of the study. So if you go with an interventional treatment of distal Leftman stenosis, so you could achieve really good 1 year clinical outcome with Resolute Onyx stent. There were numerically fewer serious adverse events with provisional approach, and it was clear procedure time, X-ray dose, and you spend more balloons, more wires if you go with double stenting. And I think this is also interesting and important information on the 20% of patients in provisional stenting group required second stent. This is, I think, very acceptable, and that's really, from my point of view, real world scenario. So finally, we have a clear message. You can go with provisional approach, and if there is a need for Cypron stenting, you can go with TAP or Collot. And if you just take a look, how is the difference between EBC MAIN study and Dickey Crash 5 study? You see that both studies were very similar according patients number. 11 countries in Europe, here 26 countries in Asia, mainly in China. Syntax score in EBC MAIN 23, definitely higher in Dickey Crash. And also side branch lesion length, 7 millimeter versus 16 millimeter. And this is suggesting that in Dickey Crash 5 study, more complex patients were randomized. Here, crossover in EBC MAIN study, 22%. Very high crossover, nearly every second patient achieved double stenting in Dickey Crash 5 study. Here, Collot, TAP were mainly used in EBC MAIN study. In Dickey Crash, of course, 100% Dickey Crash in double stenting group. And IVUS, I think this is also important, point to discuss with Bea. IVUS was used only in 40% in both studies. So we have many meetings and try to get higher incidence of imaging during distal Leftman stenosis. But even in high volume centers and even in pre-selected high volume centers and in this topic of distal Leftman stenosis, IVUS was not used in 100% of cases. So similar endpoints, however, here in Dickey Crush we have cardiac death, and ABC MAIN study we have all-cause death, and we have here 15 versus 18% and 11 versus 5%. So the data from a result was significant in Dickey Crush 5 study and ABC MAIN study. We wanted to show superiority of a provisional approach, but then finally we miss this superiority. So the difference is not significant. And I just show it you here, this 5% in Dickey Crush. And if you just take a look to the BBK2 trial, which was published a few years back, you see we had similar results, nearly 7% target lesion failure after 1 year, and we had here around 50 distal Leftmans in this study population. So in summary of this study, before we go to discussion, so I believe we can go here ahead with this simple advice. If we really have to treat relevant sideburn stenosis, and we have through bifurcation, and it means we have complex through bifurcation, then you can go with systematic two-stent strategy. In non-complex through bifurcations, it's a equivocal evidence, so you can go with single or double stenting. In non-true bifurcation lesions, there is evidence for benefit of single stenting, and if you have trivial bifurcation, there is no dedicated studies according to this point, just sideburn stenting or intervention only as bailout. Thank you so much. And now I think we should discuss the results with Bea. Bea, are you surprised according to the data from ABC MAIN study?
Well, thank you. I'm not really surprised about the results, because when you see the previous data almost in Europe regarding bifurcations and Leftman, was similar data by non-randomized trials. So we weighed that in a randomized trial was similar. To be the more surprised, and there is a question from the chat that they asked us about the IVUS, because the IVUS, the rate was really low, and they are asking why is the reason of that. Because, for example, in your center, you use IVUS in all the cases or not?
No, we don't. To be honest, we didn't use. We had a similar rate like in study, the study result. We could compensate this with our, I think, really a huge experience. We treat for many years hundreds of distal Leftman cases, and for many years we had really option to get angiographic follow-up, and then we had this information how is long-term follow-up after our PCI strategy. And I think we still, to be honest, we still have to implement more often imaging, and I think for younger doctors it's obligatory. You know, they have to learn, they have to see how is the diameter, what they believe, and how is the diameter in the IVUS or in OCT. And I think.
But do you think that in protocols they must to obligate to investigators to do IVUS? Because I think it's the first point, not to do IVUS in protocols. Because it's the only way to obligate you want to enter in that study, you must to do IBUS if you do a left main, because we need this data to show people that with IBUS you are better results. And maybe you classify better the left main.
Finally, we know how to manage now complex bifurcation lesions according to the technical approach. We have very good wires. We have now excellent stents available. But I fully agree with you. We could still improve our data if we would implement imaging more often, more frequent. I fully agree. How it looks in your center, if you go to distal Leftman stenosis,
My personal impression is that in my center, for left main, we use 100% of the cases. But maybe we publish and it's not true, because sometimes you think you do a lot, and at the end, maybe you don't do as you expected. But I think that we do in all complex cases IBUS, but maybe because the patient is really unstable or something like that, you want to finish, and also you have experience that you are going to do kissing and pot, and you are going to do regarding to the distal vessel diameter, because you have experience and you always overestimate your experience, so you do prefer to do fast. So maybe I don't do as I think I do.
Yeah, I think last Thursday I had a really interesting case where I was using IBUS after very complex left main case. And to be honest, I just could confirm, okay, everything is fine. And this was, so there was no need to perform corrections. But okay, I could see practically and say to the patients, okay, everything is perfect. There is no need for corrections. But I think you need really a lot of experience. You have to do many cases. And if you start with PCI, it's mandatory if you go with IBUS to get this experience.
Yes, I agree with you.
So, Bea, let us maybe show now a few cases from the study population. And so we included around 40 patients in our center. And we had one of the patients had focal stenosis in the circ, and this is usually a problem if you perform double stenting of circ. If problems occur, it's usually proximal ostial circ. And one patient were really very diffused, had this diffused in-center stenosis, so we decided to send the patients to surgery. One patient had a mixture of focal in circ and a longer stenosis in proximal LAD. So this was also managed first by PCI, and we told to the patient if there will be restenosis. So then one chance with drug-coated balloon is okay, but then in next step we would definitely send the patients to the surgery. So let's take a look now to. Can you see this slide now?
No.
So I probably have to just share my screen again. And yeah, this is
Yes.
This is a one I think interesting patient, and this is a culotte approach, and symptomatic male, 76 years old, and good LV function. And so you see, this is the stenosis of this Leftman. So you would just say, okay, Medina 0, 1, 1. I think it's really necessary to check always second or third projection to see how it looks. There was some LAD lesion here, and the topic is a calcified circ, and you see in this spider view. And what we believe in such cases, if you see here a lot of native calcium, so we try to go here with rotablator, with rotablation to perform the bulking. And then finally there was a maybe small dissection here, and finally prodilatation and stenting of LAD distally, then kissing. So finally we had here suboptimal, definitely suboptimal result for LAD. That's why we went with one more stent. And we had also problems here with proximal area. So we tried to cover complete Leftman. It was not really long. And finally, we could achieve this result, which was, I think I was really quite happy, because there was a lot of calcium here in both LAD and LCX. And finally, we could achieve here quite good angiographic result. And here one more projection for this LAD. So the diagonal branch we'll let it, because it's really around 1 millimeter vessel. So I think we could manage this distal Leftman bifurcation lesions with 2 onyx stents really very nicely. And this is one of the patients with angiographic follow-up. And you see there is a focal instanter stenosis. Here you could imagine the patient was again symptomatic. So what we have done, predilatation with very short non-compliant balloon 3.5, and then drug-coated balloon, and finally we could manage this case. And why I was asked, I asked it after this patient. So here is still fine. So the second case, which is I think also important because it's bailout, symptomatic male, 61 years old, normal LV function. You see this is really subtotal distal Leftman with a problem primary in ostial circ. There was some ulceration here maybe, and also huge circ, as you can see here. And so the focus was to stent from the Leftman, lesion preparation, of course, prodilatation, and stenting from main branch from Leftman to LAD. And so the wiring was successful, prodilatation and stenting with pod, kissing, and we use it here, pressure of around 12-14 atmospheres and final pod. And you see there is this dissection at the ostium, and there was more than haziness here in this huge circ. So we finally believed there is definitely better to go with a stent. And you can see how important is to take your time and to place the sidebranch stent in tap position. You need 2-3 different projections. You have a balloon in the main branch, just prepare it, and you should cover, definitely you should try to cover the ostium with the sidebranch stent. So protrusion should be around 0.5 millimeter. You check this in a few different projections, and finally you go here ahead, go with kissing, and this is a kissing with non-compliant balloons. I think this is very important information to you. You should really take a new balloon here to the circ, and we usually take then a non-compliant balloon. This is, I think, very important information, final pod. So we could achieve here quite nice result for this young patient. And so LAD was here fine with huge diagonal branch. And so we were ready. And this patient came 6 months later, and as you can see, so we were very happy with huge 2 large onyx stents. We have here really very nice long-term follow-up. And the next patient is quite interesting, 67 years, and again with non-STEMI is a constellation, so acute coronary syndrome, troponin positive. And if you see this left main, you could imagine, yeah, that's clear. It's very, very critical. This the Leftman stenosis, but however, a short problem of ostial circ, but very hazy lesion, and so we decided to go here ahead. Placed wire just in case, because if we engage the guiding, so we had no pressure, it was really a bit critical. So then you go with second wire stand from the main branch, from left main to LAD pod, then kissing, then final pod, and as you can see here, we could achieve here quite nice result for the left main. What we have done in next step after the stabilization of the left main problem, we went to the LAD and put it 2 stents to the LAD, kissing with a huge diagonal branch. So finally we could achieve here quite nice result. This is before. So we started to work here in LAD, which was long lesion, and finally we could achieve here I think very nice result for the left main and for this huge bifurcation LAD diagonal branch. So the question was how it looks after 6 months, and you see this is exactly 6 months later, and I was really very happy to see this very nice result for the circ. So you see, and patient was free of symptoms, so we could leave it. Again, 47 years old, female, symptomatic female, and this is again distal Leftman stenosis with subtotal lesion of circ. And as you can see, it was really important to wire circus at first, because it's angle angulation, it's not so easy. And if you go here subintimally, if you would go subintimal way, this will be very, very critical point. So and we could achieve this quite nice result with 2 large onyx stents with 4.5 diameter of post-dilatation, 5.5, and this is just to show, we don't have so much time, just to show angio after 6 months, excellent result for the circ and LAD ostia. So I would suggest, we saw now a few patients from the study population, and now I think they are. Yes. Would you show maybe your cases now, because I think it's important to have a different view from another huge volume center in Europe.
Yes, I'm going to share my presentation. Yeah. Only there are 2 questions from the chat, and I think it's important to interact with the people that are in June listening to us in the afternoon. That is a challenge. So we have a question that they ask us that, do you think we need a randomized trial of left main bifurcation with patients, IBUS versus not IBUS guidance? I think there are some studies showing that there is a benefit to use IBUS in distal left main using IBUS from Korea. What do you think about that?
Yeah, definitely. As I mentioned, that's a dilemma that on the one hand, we have even randomized studies, from Asia, supporting the systematic use of imaging. But however, in daily routine, it's really very difficult to implement this as a standard. It's not clear what's the problem. Probably we have to do repeat such study with 100% imaging, as you proposed, to go by protocol with imaging, and this will be really interesting to compare the data.
And also, we have a question regarding the FFR in the side branch, because always we have a problem with the results in the side branch, and by protocol, when you see a dissection or something like that, you implant a risky stent. But what do you think of the role of the FFR in the side branch?
This is good question and good point. I think this is also helpful in many cases to make the decision if there is no flow limiting dissection on only residual stenosis, maybe 60, maybe 70%. But if FFR is really okay, then you can leave it. We had also in this study 1 or 2 cases with FFR wire. So I use this approach in daily routine. Okay. I would suggest, because of time, you can just go with you.
I'm sharing my screen. You can see my screen?
Yes.
Okay. Is only maybe I'll repeat some concept, but I'm going to go fast for these slides. Is what we know. We know that, as you said, that KISS is the principle that keep it simple and safe. That means that maybe in nearly 80% of the cases, provisional T10 is enough, but also doing POT and kissing balloon inflation and IBUS. And only in complex left main, you can use 2-stent technique. But I think there is a difference between Europe and Asia, because in Europe, all the data we have that is not advantageous to 2-stent technique from the beginning. But when you see in Asia, we see that decay crash, that is the 2-stent technique, has better results when comparing to provisional T10 and also to comparing to culotte. So that there is a big difference. So in left main, we have a lot of non-randomized trials comparing 2 and 1, and was favorably to 1-stent. But when we analyze from Asia again randomized information, you see that there is a benefit to 2-stent technique, decay crash, over culotte and over provisional T10. And why is that? To me, it's because all the left mains are not the same. This is a slide from the definitional trial that they define what is complex left main and what is not complex left main. So we are going to see in my examples what is a complex and what is not a complex. This is one left main, and you can see is 1, 1, 1. You see the image in the right side, that there is a not long lesion in the same branch. You have big vessels. By definition, we will see that this is not a complex left main. This is the difference. You have a little more calcification. You have an angulation that is really acute, but you don't have diffuse disease. So maybe is between complex and not complex, is in moderate complexity. And what do you think about this distal left main? This is diffuse disease, this severe calcification, this is an opal, really angulation. So you have also diffuse disease in the main branch and side branch. Thus, to me, this is a really complex patient. So as I told you, this is the definition of complex and not complex. So you have to take one major criteria, that means the extension in the side branch and the severity of the stenosis in the side branch. So you have diffuse disease in the side branch with a really severe stenosis. This is one major criteria. And the minor criteria is more about the main branch and the angulation and the calcification. You have calcification, big angulation, or you have diffuse disease in the main branch, and you have 2 minor criteria. Also, you maybe have a complex left main. Because why? When they classified the left main, the distal left main, in complex and no complex, they found a difference favorably to stent technique. More complex left main to stent technique is better by the results, but TLF. So also we know by randomized trial that is true, that is one trial, that when you have to choose a two-stent technique from the beginning, the decay crash was superior to the culotte. So what is new? As Professor Ferenc said, there were different patients treated because in the decay crash, there was more disease, the syntax score was higher, the lesion left in the same branch was also higher comparing to ABC. That means the extent of the disease was greater in the decay crash study. That was the result that in 45 of patients in that study, in the decay crash, in the provisional group, they need a stent implantation, so to change to two-stent technique, comparing to the EBC MAIN. That means maybe we are treating different left main. Maybe the Asia population and the European population are different. And also, in the two-stent technique direct, the technique was different because in the EBC MAIN, when the two-stent technique was more culotte and T, and the decay crash was decay crash. So also for the other branch, the technique was different. So this is an example on no complex disease. By definition, because you have really 111, but there is no calcification. Also, there is no diffuse disease. The angulation is 90 degrees. So by definition, trial is not a complex left main. And this patient was randomized to provisional T-stent strategy. In our center, we did IBUS in all the cases, was a fibrolipidic plaque. So we did cutting balloon to left main, and you can see here the results of the cutting balloon. Then we implant a stent in the main branch. We do POT. Then we did kissing balloon inflation, and we checked by IBUS to check if the optimization, that apposition and expansion was good, and also was good. So to me, in no complex distal left main anatomy, KISS is mandatory, is the principle. That means is a ABC MAIN strategy. Provisional T-stent, POT and kissing, IBUS pre and final. If you need rescue, is good with culotte or T or TAP. But what happened with this anatomy? So this is a complex anatomy. I told you there is a diffuse disease in the circumflex, really long. This is the dominant circumflex. You have calcification, you have a big angulation, and you have diffuse disease in LAD. So here we did IBUS before and also after. You can see that here is the circumflex. This is the ostial, also left main, and then you can see the LAD, and you can see there is calcification. There is moderate calcification in the bifurcation, also in the distal left main. In the proximal, there was only moderate calcification. Also, IBUS gives you the information about the real diameter when you have diffuse disease. The distal diameter was around between 2.5 to 2.8 millimeters. This is from LAD. This patient has a limit to distal LAD, but was not working. You can see that there is diffuse disease in distal LAD, and also there was moderate calcification in ostial LAD. So we predilated everything with a relative small balloon, and then we choose a bigger balloon, circumflex and LAD. And then in that case, we use a decay crash starting from the side branch. You can see here the stent that was placed. You have a balloon in LAD. Here we implant the stent in left circumflex. Here you can see we did the crash, and then we rewire, and we did the first kissing balloon. You can see here the results after the first stent implantation. So we implant the second stent, we did the POT, and then we do the second after rewire. We did the second kissing balloon inflation, and we finalized with a second POT. And you can see here the result. The result was very good by angio and also by IBUS. And I think this is an example of decay crash strategy. That means they really refine the decay crash. They improve every year this strategy. So we need to follow careful step by step. You stand in the side branch from the beginning and you do pots and kissing repeat. And I think it's really important to do IBUS pre and final. So these are my conclusions. I think that Leftman PCI is really good or is acceptable. You have a synthetase score slow or also intermediate. I think EBC MAIN and decay crash include different distal left main anatomies, more complexity in decay crash, more culotte in EBC MAIN. And we know for distal left main with one randomized trial that decay crash seems to be superior to culotte for distal left main. So to me, we need to classify the distal left main complexity according to definition criteria. We need to do intracoronary imaging, OCT or IBUS, to help to clarify complexity, but the most important is to check the result. And to me, for distal left main with no complex anatomy, provisional T-stent is the default strategy. But when you have a really complex anatomy, decay crash to me is the default strategy. But then you have a mix. When you have a moderate complexity, I think also provisional T-stent strategy is good. And if you need to do culotte or TAP, is also a good strategy. So this is my slide.
Dear Bea, thank you so much for the summary, and I think it was a critical appraisal also for both studies. And so we should discuss this point. So I fully agree with you that in quite simple anatomy, distal Leftman anatomy, we should definitely go ahead with provisional approach. So we can usually and I believe that's really realistic number. In 80% of cases, we can treat such patients really correct using one stent approach and perform final kissing and final pot. But however, from my perspective, we have still in the cath lab 10 to maybe 20% of patients with definitely so complex anatomy, as you could show us by definition trial, then you should start with really with decay crash. Many different steps, but if you do 10, 15 times decay crash, so you will have safety in this procedure and go easy ahead. In what we do now in our center in Germany, also we started now with BBK3 trial. And this is a randomized comparison of decay crash versus culotte in non-Leftman bifurcation lesions. And I can tell you, we have now randomized around 40 patients. It's much more difficult to perform decay crash in a distal LAD area or distal circ. It's in Leftman it's quite easy, but in non-Leftman bifurcation lesions, it's by technical issue much more difficult. So we will see how the data will be.
We have some questions from the chat.
Yeah.
There is one question that they ask that the best way to go about isolate ostial LAD or less circumflex. So to me, there are not complex left main disease, because if you have disease in the ostial and you check by IBUS and distal left main is effective, there are data that they show you that it's better to stent from left main to LAD. It's not good to left the stent floating in the left main. So to me, it's like not complex left main. So I treat by provisional T-stent strategy.
Definitely.
What do you think?
What is really very important, because we know in around 80% of cases, distal Leftman is something around 4.5, 5.0, 5.5 millimeters. It's clear. So don't choose too small stents. If you go with 3.5 or 4.0 onyx, you can still go up to nearly 6 millimeters. I think this is really very important point, not to let malapposition. I think this is one of crucial points. And Bea, maybe last point, according to the lesion preparation, how is your experience with IVL in distal Leftmans? Because if you go with rota or orbital atherectomy, you have to remove the wire from another vessel. So if you go with IVL with shockwave, you can still have two wires in the place. How is your experience?
I think it's one of the indications, and when there is really a ring of calcification, lithoplasty is really effective. And when there is maybe moderate to severe calcification, in our personal experience, cutting balloon is also really good for left main. And we only treat by rota when there is an uncrossable lesion or when there is really diffuse disease with a really tight lesion. And we're risky because we don't, it's impossible or it's risky to place a second wire.
Yeah, great. I think so. As I promised you, 1 hour is running very fast. And so thank you for your contribution and discussion. So in summary, I think we agree both together. So if you have really simple distal Leftman stenosis, you can go with provisional approach. That's fine. You still have option to use bailout, culotte, or TAP technical approach. Of course, choose of the right stent is, I think, important. Now we have very good data according to the use of onyx in distal Leftman stenosis. And if you have really very complex stenosis, I mean calcified, long lesion segments, then please consider there is option also to go primary with Dickey Crush, and for that we have really excellent data. And lesion preparation, as you mentioned now with IVL or debulking, is extremely important. Of course, post-dilatation with large balloons. Okay, thank you so much, dear colleagues. It was a pleasure to make this seminar. Thank you for Medtronic and InCathLab to organize this webinar. Thank you so much, and
thank you.
Thank you. Bye-bye.